So this is the very first clinical trial in which patients with CLL who uniformly had received a prior covalent BTK inhibitor were enrolled in a prospective randomized phase 3 study. So the reason that's important is I think that there's a general misperception um, in the community, not necessarily in community practice, even amongst academic thought leaders about sort of the nature of these patients who experience resistance or progression on a first or second generation BTK inhibitor. Now, in this particular study, this was a randomized study against investigators' choice therapy. Now, investigators' choice is a little bit challenging because there's no defined standard. So, what do you do after somebody's had a prior BTK inhibitor? And the answer is we don't know. Many patients would go on to receive a BCL2 inhibitor, and that's fine. However, half the patients in our study had already received a BCL2 inhibitor, so clearly there's no standard for those. And we also know that some patients are sort of biomedically unsuitable for a BCL2 inhibitor. So we chose a investigator's choice, which was agreed upon by the FDA, which was either bendamustine rituximab or the combination of idelalisib with rituximab. And patients were randomized 1-to-1 to either investigator's choice or pirtobrutinib. If patients were randomized to the control arm uh, and they demonstrated progression, they could then cross over to pirtobrutinib, which certainly impacted some of the variables that we commonly measure in studies like this. Um, but that was the basics of the study design. And then I guess the second half of that question is, who enrolled in this study? This was a very, very sick population of patients. Um, Roughly 70% of the patients on the experimental arm had some form of TP53 disruption, either by way of mutation or deletion, a high number of complex karyotype. Median prior therapies was three. Half of patients received prior BCL2 inhibitors. So this was a very sick population of patients who were then randomized to the study. What we found was that the patients randomized to pirtobrutinib did better in terms of the key primary endpoint, which was progression-free survival, but also that safety was considerably improved over investigators' choice as well. So the patient sort of won in two dimensions, both safety and efficacy. The median progression-free survival was 14 months as opposed to about 7 months. And, um, 14 months may not seem as good as people were hoping for, but I sort of highlight again the acuity of these patients, but also point out that many of the patients treated with pirtobrutinib, when they did progress, appeared to have sort of asymptomatic radiographic progression, sort of almost a feature of the clinical trial in which CT scans were done more frequently. If you actually looked at the time to next treatment, that was closer to 2 years. And in the venetoclax naive patients, it was sort of 2.5 years. And the venetoclax previously exposed, it was closer to 2 years. So, there was a benefit to the drug even beyond sort of IWCLL criteria for progression. And I think the punchline there is that is the molecule that is effective. It can control the disease for a length of time. It doesn't solve the disease, of course, and we will have additional studies reading out in which venetoclax rituximab with or without pirtobrutinib uh, is evaluated, and that's going to be important for sort of the other half of the patients who might be venetoclax naive. Um, and I think the safety was considerably improved as well. There certainly was some pneumonias, some neutropenias, but if you looked at sort of all the other safety variables adjusted for the time of exposure, we saw statistically significant improvements in patient outcomes with pirtobrutinib.